Hello, my name is Professor Peter Detmar, and today I'm going to introduce you to PEPTEST, a non-invasive reflux diagnostic device and the role it plays in the management of reflux-like symptoms. I'm first going to introduce you just generally to reflux, and in particularly the role of pepsin in reflux. So this first slide really is quite a general slide. We're talking about reflux from the stomach, up the esophagus, into the airways, into the mouth, into the throat, etc. And it's estimated that GERD and airway reflux affects about 20 to 40% of the global population. We do know that pepsin in particular is present in all refluxate, which is in contrast to other gastric components such as acid and bile acids. And this is generally because of the pH of the refluxate, as pepsin is so active over a large pH range. Pepsin analysis is performed on samples of saliva and sputum, but there's also some other media it can also be detected in, which I'll cover later on. And pepsin is considered as a very sensitive and specific biomarker for GERD, LPR, which is laryngopharyngeal reflux, and a lot of the respiratory diseases which are associated with reflux, which is another point which I'll cover later in the presentation. A little bit about pepsin to introduce you to it. Pepsin was first discovered back in 1836 by Theodore Schwartz. In fact, it was the first enzyme to be discovered and the second enzyme to be crystallized. So it's got a reasonably short history. Whereas pepsis or pepsis is a Greek word which means digestion, which has obviously been around for centuries. And the early literature reported its role in breaking down proteins in the stomach as its major action. So getting back to pepsin itself, it's a major component of gastric refluxate, as mentioned earlier. There's a whole family of isoenzymes of pepsin. Now the pepsin complex which we work with mostly is called pepsin 3 complex, which comprises pepsin 3A, 3B and 3C, and in fact is the basis of our PEPTEST. The main activity of pepsin is in the acidic environment, pH 2 to pH 4, where both pepsin and acid are active. But pepsin itself is active up until pH 6.5 and not actually denatured until it reaches pH 7.8. There's quite high concentrations in the mammalian species, obviously, which includes humans. And this concentration can be up to 1 milligram per mil found in the stomach. We've managed to identify pepsin itself in various gastrointestinal diseases, which I've listed here on the slide, including GERD and LPR, respiratory diseases. Very common, reasonably common anyway, in chronic cough and asthma and COPD. And it's also quite common in otitis media with infusion. Now we use saliva and saliva sputum as our main detection media for detecting saliva in clinical samples. But I've listed here some other areas where we can measure it. Tracheal aspirates is very common. Broncholavage is very common, especially in respiratory diseases. And laryngobiopsies is another common way of taking samples directly from the laryngeal region and determining the pepsin concentration. So now a little bit more detail on PEPTEST itself. We started to develop PEPTEST as we know it now in 2004. And it was a very early concept. We used pepsin as a marker for reflux over other digestive enzymes and bile acids. There's a fair bit of literature around before we started this work in 2004. It basically goes back, I showed you when it was first identified, but the fact it's a biomarker goes back until maybe the early 90s. Now, we developed pepsin monoclonal antibodies, which is absolutely very key to PEPTEST. We identified and developed two of these, two very unique human monoclonal antibody species. And these we developed to human pepsin 3, which I showed you earlier, which is about 80% of the total pepsin which you find in a human gastric juice. Once we had these antibodies, we could then use these to help develop lateral flow devices, which is the basis of the technology for PEPTEST. Once we had that developed, we launched the product first in the UK back in 2010 at a human pepsin conference. An introduction to PEPTEST is a marker of prior reflux, which enables rapid detection of pepsin in specially saliva samples, but obviously you can use other formats, as mentioned earlier. And we've got it fully validated in GERD patients, EER, which is extraesophageal reflux patients, and LPR, which is laryngopharyngeal reflux patients. We now have it commercially available worldwide, which again is a point I'll cover later in the presentation. The format is a lateral flow test format, and it contains these two very unique anti-human pepsin monoclonal antibodies. So this is how it works, really. The two antibodies, one is to detect the pepsin in the clinical sample, and the second antibody is to capture it at the site of the test line within the lateral flow device. So the antibody is positioned just below the well here. It's then carried through by a migration buffer through to the T line, and if there's pepsin present, it's then captured at the T line and will light up blue. This is a very simple description of really how it's done. The first is we ask the patients to spit into a tube. That tube contains a small amount of citric acid. This is to make sure that once the pepsin is collected, it doesn't auto-digest itself. So the citric acid will make sure that doesn't happen, and it can actually be stable for between 5 to 7 days. We then centrifuge these tubes for 5 minutes at 4,000 RPM. We then draw up 80 microliters from the tube into a migration buffer. We vortex mix very, very quickly, just a 10-second mix to make sure it's well mixed. And then we take out 80 microliters of that mixture and add it to the well of the PEPTEST. And this last diagram here just shows you that if you've got no pepsin present, you'll just get a control line. In other words, the T line will be empty. If you have pepsin present, you'll get a T line and a control line. And if for any reason the study's gone wrong, the sample's gone wrong, you'll get absolutely no lines at all. But the invalid test is very, very rare. We can quantify the results. We have a reader where we can literally look at the lateral flow device, the PEPTEST itself, and actually get an intensity reading of the T line and measure the concentration of pepsin in nanograms per mil. This we do at 15 minutes after adding to the lateral flow device. In the UK, and in fact in some other countries, but this is really basically what happens in the UK, we send patients or provide hospitals with collection kits. The collection kits, it comprises of 3 sample collection tubes, and these are distributed by either us or our distributor, which in the UK is Biohit UK. The patient then provides their sample, so we give them full instructions of how to provide the sample, when to provide the sample, and then these samples are then returned in the normal post back to our central laboratories for analysis. And then the results are sent within 24 hours, 48 hours absolute maximum, to either the clinician or directly to the patient or both. So how is the data used, which is always a question we get asked? Well, if there's no pepsin present at all, you'll get an absolute 0 at the T line, so it'll be absolutely blank. You'll get a control line, obviously, to show that the assays worked, but you'll get 0. If there's a minimal level of pepsin, you'll get a very, very, very faint line. So this really is initiation of lifestyle changes, and we recommend you then would retest in 12 months. You certainly can't claim you've got high levels of pepsin if you just get this very marginal line. If you have low levels of pepsin detected, and it normally equates to about 75 nanograms per mil, again, we recommend lifestyle changes, which we tell patients about, and we retest within 6 months. A moderate level of pepsin we estimate to be around about 125 nanograms per mil. We recommend to treat those symptoms and associated reflux disease and monitor the changes and retest within 3 months. Now, if you do have a high level, and high levels can be anything between 200 and 500 nanograms per mil, this is pathological reflux and certainly needs treatment. And we recommend various treatments and obviously lifestyle changes and dietary changes. And we would recommend that patients are then regularly monitored, which you can do with PEPTEST, because you can treat patients for maybe 4 weeks or 8 weeks and then retest and see if that treatment has actually lowered the amount of pepsin in the sample. Now, we've done various validation studies throughout the world, and this is just merely just 2 of them, which were done reasonably recently. There was a very large GERD study done in over 1,000 patients in China. This was published in 2019 and was done on non-erosive reflux patients, functional heartburn patients. And it showed that overall the sensitivity of PEPTEST to detect reflux in these patients had a sensitivity of 85% and a specificity of 60%. We then did another test which was done in laryngopharyngeal reflux, and this was carried out in 5 major UK voice clinics in the UK. Again, this was done in over 1,000 patients. And again, it showed reasonable sensitivity of 76% with a specificity in this case of 100%. So this paper was published in 2020. And if you ask BioHit or you ask us directly, we can certainly supply you these publications. Now, I mentioned respiratory diseases earlier on. So we actually routinely do test PEPTEST for the prevalence of pepsis in patients presenting with, I've given you a long list here, from chronic cough through to asthma, through to cystic fibrosis, to pharyngitis, etc. And you'll find that a lot of these diseases, these respiratory diseases, are actually associated with reflux. And we find the association to be round about anything between 60 to 80% of these patients will have associated reflux disease. So it's really very important that you consider testing respiratory patients for the presence of pepsin, and you can either then build in reflux treatment into those, or if there's no pepsin present at all, you can dismiss reflux as a cause of these symptoms. Now, we often get asked about PEPTEST versus other invasive tests, and the invasive tests in this case are usually 24-hour pH test, which is quite commonly used in reflux patients, or maybe more of a gold standard is impedance with pH. So I know this might be difficult to see, but I've just highlighted here just some tests which have been done where we've compared directly PEPTEST itself with the sensitivity specificity in using other invasive tests. And as you can see, these tests are done throughout the world. Some are done in Italy, UK, China, Turkey, America. And what we normally find is that the sensitivity and specificity of PEPTEST is normally again in the 70s and 80% margin. And they bide very, very well against these more invasive tests. And obviously they're much quicker to do. You can get a result for pepsin in your clinical sample within 15-20 minutes using PEPTEST, whereas with the invasive tests, you're going to have to wait a long time, at least 24 to 48 hours, if not longer, to get some sort of result. There are well over 100 publications. I think in the latest count now, this was back in 2020, we have at least 130 to 150 PEPTEST publications, and these are from clinical groups tested throughout the world. And this just is a very, very small selection of some of the key papers which have been published in the very recently. We have them from China, the UK, from Italy. We can supply you with publications, but they're also available on our website, and I'll tell you about the website right at the end. So PEPTEST is available in various international markets, and I've listed here some of the key markets where PEPTEST is now registered and freely available. From the UK at the top, I mentioned the launch in 2010. It's been in Italy for quite a long time now, nearly 10 years. It's freely available in the Czech Republic, Belgium, across Asia in India and China. China is a very, very large PEPTEST market for us. And we have registrations ongoing in Singapore, South Korea and Vietnam. And it's also been registered with the FDA now since 2017. And we're getting registrations in other South American countries. Just to remind you that PEPTEST is a non-invasive, very rapid diagnostic reflux test. This just gives you some idea about the range of patients which is tested in, from GERD, which we've spoke about, laryngopharyngeal reflux, LPR, through to extraesophageal reflux or airway reflux. It's also reasonably commonly used in the critical care arena, in ICU, in organ transplants, to see if patients who are having an organ transplant are subjective to reflux disease, and if they are, they have a treatment for reflux before they're transplanted. Respiratory diseases we covered, which are chronic cough and asthma, and there's a very large cohort of reflux in pediatrics, from neonates from 0 to 6 months through to infants at 4 years, right the way up through teens. Reflux is really quite common. And because PEPTEST is so non-invasive and easy to use, we even get the parents to collect saliva for us, which could be merely secretions from the child, from the baby, from the neonate, which can then be tested to see if it's got the presence of pepsin. And if it has, these children can then the diet can be altered, or they can indeed be treated with reflux medications. So in conclusion, PEPTEST is recognised as a biomarker of reflux disease. It's available as a first-line rapid and non-invasive reflux diagnostic test in many countries in the world now. It's been fully validated in GERD, extraesophageal reflux and LPR, and is also available in primary care. So thank you for listening. I hope I've given a fair introduction to what PEPTEST is and how it can work. There's a peptest.co.uk website where you can look at some more further information, and certainly you can get some of the publications I mentioned off that website. And there's also a YouTube PEPTEST reflux, where you can actually watch the test being done and you can see how simple it is. It is really quite simple. Once you've done 1 or 2 tests, it really is very simple and very, very quick and rapid. So thank you again for listening. Goodbye.